Good afternoon, everyone. Welcome to Teletlagery Symposium. My name is Malhar Soni, and we will have some interesting discussion on some of the controversial topics in relation to detachment of retina, macular surgery, and endophthalmitis. We have very experienced faculty with us who speak the politically incorrect language, so I'm sure it's going to be fun. So just a brief thing about Mission Tilly. Mission Tilly is all about how to achieve near 100% anatomical success and near 0% morbidity. It's all about aiming higher and higher. So it's all about what would you prefer if it's your eye. And before I start the case examples, I just want to show one video just to show what I mean by Mission Tilly.
Just look at the history of everybody doing big projects, and it's never driven by exploration. It's never driven by science. It's never driven by curiosity. Not if it's big and expensive. It's driven by the fact that people don't want to die. So there's a war driver. It's also driven by the fact that people want to get wealthy.
No, hold on. We have the Large Hadron Collider.
The Large Hadron Collider. Do you know?
Oh, no.
We will try our best not to end up in a situation like that. But if we have to, we are all for it in a good spirit. So before we start, a message from our good friend Bill Maher.
If you're not upsetting some people, you're not really being brave. If everyone likes you, you have never said anything true. Anytime you speak the truth, some people are going to hate you.
Bill Maher? So panelists, friends, you know that. You need to speak the correct language, and you know how to. So it's a very basic first question. So definition of success for retinal detachment surgery, and I kept it mainly for the new generation of retinal surgeons or the fellows in the audience. My personal understanding is that the surgical success with one surgery for lifetime without any internal tamponade, and I'm interested in quick view from the panel members. Didier?
I think that there is a big difference between US concept of retinal success and European concept. US concept, you are interested in obtaining curation in one time, even if the final vision is lower. In Europe, we don't care about the number of operations. The interest is the final vision. For me, having to put and leave the silicone in the eye is a failure.
Sure, totally agree. Klaus, would you agree with the idea that single surgery success without an internal tamponade for lifetime should be the aim? Of course, it's difficult to measure that because we need significant long-term follow-up assessment, et cetera, but just in principle, and mainly to raise the bar for the fellows to understand and make sure that they follow the basic principles of indentation, ora serrata examination, making sure they follow the right path for doing the right surgical management for a given eye. So simple. Do you agree in principle with that?
Yes. Certainly.
Sure. Okay, that's good. All right, so the next question, it's all about a case example. So what would be your choice of surgical procedure if you develop a retinal detachment as shown here, and you have an access to your choice of surgeon, Abdish?
That's a great question. The trouble is that there have been studies that demonstrate that physicians make different choices for their patients than they make for themselves or for their own family members.
Exactly.
And it can go both ways. We can either be more conservative when it comes to recommendations for our patients, or we can be the opposite, more cavalier. And I think it falls more on the opposite side, that we're more conservative with ourselves and more cavalier with other patients.
So the simple answer, if it's your eye, what's your choice?
Yeah, I probably would say do a buckle.
Uh-huh.
Or I'd say do a pneumatic.
Pneumatic?
Yeah.
I would prefer pneumatic if it's my eye. Jersey?
My choice would be pneumatic retinopexy.
Pneumatic. So raise your hands, please, if all support pneumatic retinopexy, or who doesn't support pneumatic retinopexy? No? Pneumatic retinopexy?
It's not as simple as that.
Sorry?
It's not as simple as that.
Sure, agree with that. Just to show some interesting slides, this is Beaver's survey. It's called British and Irish Association of Vitreoretinal Surgeons survey. And we asked this question in 2011. that do you perform pneumatic retinopexy? And as you can see, and yesterday Ahmed Salam mentioned that that's frowned upon technique in UK. So almost 95% respondents in UK responded that we don't prefer to use this technique. But the result of the next question was very interesting, and here's the question. If there was an incentive for successful retinal detachment repair with pneumatic retinopexy, would you prefer to do it as a primary procedure based on selection of cases? And guess what? Nearly 38% responded that yes, we would always do that. Now the message here, it only means that they believe that pneumatic retinopexy works, and that's an important message, mainly again for the fellows or the new generation of the surgeons here. And this is from earlier studies that if a pneumatic retinopexy is done properly and fails and a prompt rescue operation is performed, the eye is not disadvantaged by the pneumatic procedure. In other words, there is no downside in trying pneumatic retinopexy first in eyes that meet the selection criteria. And I'm not at all suggesting to experiment here. It's all about proper training, learning from the real experts in this field, and then try. So looking at my journey of retinal detachment repair, I had a privilege to get training from the surgeons who were trained by Charles Keepens, and I started managing RDs with scleral implants. Then 23-gauge vitrectomy since 2005. We were the first in the UK, 2000, and then 25 for the last few years, but I still prefer to perform scleral buckling and pneumatic retinopexy for RD management for particular cases. So I think it's an important point here is to select the least invasive operation that would provide the greatest chance of success. And one needs to be careful in reading the misleading statements in literature, as mentioned in this SPR study group comment. I'm just reading it as it is. In unclear hole situations, it is unnecessary to search for breaks for several hours or days because it is highly likely that these breaks will be detected during the vitrectomy operation. The patient will leave the operating table with a reattached retina, surrounded by an internal tamponade, and with the belief that all breaks have been identified and treated. This leads to more confidence for the surgeon compared to the worries one might have because of patent breaks with residual detachment. Now, this type of statements make me furious. It's absolute nonsense. Klaus, do you want to comment on that?
No, but I would like to comment on the whole discussion, because I think it's not as simple as that. If you show me that picture with the 12 o'clock hole, the next thing I want to know, how old is the patient? Is he phakic or pseudophakic? Has he been suffering from floaters? There's so many factors that go into it. Is it on a Friday afternoon when my surgical team wants to go home? There are so many factors that factor into this, because you've got several options here. You can buckle this case, you can pneumatic this case, or if it's a
What I said that if it's your eye,
huh?
if it's your eye.
My eye personally at this very moment, I think with the floaters that I'm having, I would go for vitrectomy.
Farin?
Let me answer this question a little differently. What I really want to address is this question of what if it's my eye? Because on one hand, it's a very good question because it makes the question for the surgeon personal, rather than just a piece of statistics about all of his patients in general. But one thing I learned over the decades, starting from medical school, is that this question is actually impossible to truly answer unless you truly do have the problem. So we can say, we think that if that eye or that retina is in my body, what I would do, but when it really develops, a lot of people will make different decisions compared to when the question was originally asked without him or them having the disease. And I don't want to spend time coming up with examples of my own life about this, but I will tell you one thing. I did have cataract surgery in both of my eyes. So when you talk about cataract in general, the question is, when you have it, what will you do? And of course your answer is, well, I go to a very good cataract surgeon. When it came to my own eyeball, I did not go to a very good cataract surgeon. I went to a very good vitreoretinal surgeon who also does cataract, because I knew that if during the operation he says, oops, he will not tell me, never mind,
We'll manage.
You know, everything is fine, come back in 3 weeks, and then my friend will fix you, because I wanted it to be fixed then and there. So my point is, and I'm not trying to make this as a joke, be very careful when you say to the patient who asks you this question, what if it's, you know, your macular hole, doctor? What would you do? You can, you know, honestly give an answer, but I will guarantee you when you have the macular hole, you will have a very different viewpoint when you're, you know, horizontal in the bed and not vertical at the bed. Do you want me to give some other answers, or we are running out of time?
I think we need to move on. That's a good point. But I would like to know, which anesthesia did you prefer? Was it a needle, local anesthesia, or?
I had 2 people dying on my operating room under general anesthesia. That's one very powerful argument. But I also, because I do a lot of trauma cases, I do prefer being able to talk to the patient during the operation. So if I have a choice, I would go for local.
Sure. Yeah. Okay. So,
I think on your prior slide, just the most important point that I would make for a take-home message is that people do not learn how to do correct scleral depression with thorough examination of the peripheral retina today. That's why they're writing statements like in unclear hole situations. What's an unclear hole situation? That means you didn't find it. So there are 2 different things, a detachment that has no hole or a detachment which you didn't find the hole. And I think they're talking about the one that you didn't find the hole. And I don't think it takes days to find a hole. I think you need to do proper scleral depressed exam, and that, I think, would be the #1 take-home message for me.
absolutely, couldn't agree more. And that's why I was trying to highlight that that's the primary thing, and to also be aware that there are various options. I respect Ferenc Kuhn like anything for trauma and ophthalmitis and a lot of other things, but I think I would like to disagree with you on that I would prefer to, and if it's my eye, I would certainly go for pneumatic in this case, the picture which I showed, and one needs to be aware about all the options or tools in armamentarium to achieve the best possible anatomical success with least possible morbidity. So moving to another one, now John Paul, that's the ultrasound of total closed funnel detachment posteriorly, as you can see, and that's a 30-year-old male patient with history of trauma, it's 4 months after the initial injury, patient was referred to the clinic. So the first question, would you encourage the patient to undergo surgery? And if so, what would be your preferred primary surgical choice? Of course, it's vitrectomy, but how would you manage that?
Obviously, it seems to be a closed funnel with PVR, very severe retinal detachment with poor prognosis. So I will explain it clearly to the patient. Maybe it's generally we do with surgery, we say it's the best, it's the only chance to give a patient good eye and good evolution, but it depends. We have to deal with the patient, and it depends what he wants,
sure.
What he expects on his eye.
Yeah.
But there is no clear, strict indication for operation. So
the 30-year-old male, other eyes okay, and that's a different situation than a 65, 70-year-old, maybe 80-year-old patient with this situation. So that's why the question, Jerzy, would you discourage the patient to undergo surgery, or would you operate on this eye if the patient is happy to take all the risks?
If it is, of course, ultrasonography is not enough for me. I would like to see the fundus in this patient because sometimes the fundus shows you more details and you can decide to do surgery or not. Second, what is the shape of the another eye? You said it's okay, another eye.
So just consider
what
that
are
other
the
eye is completely
expectations
normal,
of the
6
patient?
vision. Well, expectation is I have a long life, possibly, and I would like something to be done for this eye. That's the simple 2-line statement of
So
mother.
probably I would advise him to do vitrectomy.
Keith,
But
would you operate?
explaining that that visual acuity afterwards may be low.
Sure, of course. Any comments, Keith?
Yeah, I think this is a great example for the most important thing that we do for every surgery that we do is really managing the patient's expectations. I think the comment that he made to you, because this is an eye that obviously, in my opinion, has a very poor prognosis, I think the patient should be discussed with that in clarity so that he understands that the prognosis for repair here is quite poor, and that even with repair, he's likely not to sustain any significant visual improvement. That's the most important thing about the patient, about telling the patient. If he, having been told that, understands that and wishes to proceed, then yes, I would try to repair this eye, but that would be the circumstance under which I would do that.
Sure, close.
The one most important piece of information on the slide is 30 years. You never know what's going to happen to the other eye in the next 65 years. So 30 years for me is a clear indication to motivate the patient for surgery. I tell them, all you have to lose is time and an operation, but you might gain a spare wheel. And going on a 60-year trip without a spare wheel is pretty stupid, even if it's a wooden square spare wheel. But that spare wheel is better than none.
Exactly, and the same thing I did with the patient because I thought that was, here it's just my error, it's 18-year mentioned, but that's 30-year-old male. And perception of light, that's the vision, and you will see Jersey, that's the fundus picture in a second now on the right side, so that's what you can see. And I went ahead with lensectomy primarily, vitrectomy, subretinal fibrosis we'll see in a minute, but on ultrasound there was very clear subretinal band. And so just inducing the PVD and then tiny bit of heavy liquid just to have an extra pair of hands posteriorly which can support some of the retina. And you can see gradually that was opening up. And after that, I realized that there was a quite large peripapillary subretinal fibrosis, as you can see here, and that's the disc behind that, and that's the subretinal band, which was obvious on the ultrasonography. I just used the forceps, closed forceps tip as a soft instrument just to open the bands between the...
Training school. When the retina is attached, there's a subretinal strap. He takes a trocar, puts it in post-equatorial.
And the idea was to preserve as much as retina as possible, but in periphery, it was not only subretinal fibrosis. Now, that's the big area of peripapillary fibrosis, and there was no other option than just to create a break there with the forceps and pull out. So that was not, you can see that's the big one. So that's where I decided to do 360-degree retinectomy because it was not only subretinal, but it was significant intraretinal fibrosis. So there's no way you can fix that except for doing retinectomy throughout 360-degree and making sure that you remove the anterior flap as much as possible, not as much as possible up to aura because you don't want chronic hypertonic situation at a later stage. So the reason of keeping this video is, as Klaus mentioned exactly, that it's a 30-year-old patient and it's a long life and you never know what's going to happen with the other eye. This eye finally ended up with 636 vision. It required only one surgery primarily and then silicone oil removal. It was 1,000 centistoke. Maybe it worked in this case, may not work with one surgery in other cases, similar situation, but I think the message here is that it's a good idea to encourage the patient to undergo surgery. Right, now, I never used, sorry, Karan.
Just a couple of comments. First, I fully agree that the condition, the good condition of the other eye really should not be a deciding factor in whether you recommend or accept surgery for this eye or not. And it's simply due to, as Klaus said, Murphy's Law. If something happens to the good eye, and we know if something happens, it will happen to the good eye. By then, it may be way too late to do anything about this eye. And we are not only talking about vision when we do surgery for this eye, but if you don't do surgery, this eye will go to phthisis within a few years. So as a minimum, you have a chance, no more than a chance, to preserve the eyeball. But as you can see, you can achieve exceptionally good visual improvement if you are persistent and do proper surgery. But if I may make one technical comment, and
Sure.
It's not about your video, obviously, but in general, because I see a lot of patients who come to me with this procedure having done somewhere, and there is a reproliferation. That reproliferation almost always comes from the posterior hyaloid not being detached central to the line of the retinectomy. So if my advice is, if you do retinectomy, especially 360, make absolutely sure that the line where you cut the retina is central to where the vitreous has been detached. Because you can't detach the vitreous to the periphery in these eyes, obviously. So there is a line where there is still vitreous. So cut the retina central to that.
Sure. And other point was that there's a lot of time I observe that patients coming from somewhere else operated, the lensectomy or lens management was not done, thinking that, okay, we'll manage at a later stage, maybe half retinectomy. So to do step by step in this situation is not perhaps a good idea, just to do aggressive treatment one go, and that has the highest possible success chances. Steve?
Look from the preoperative ultrasound as if this was a hypotenuse eye as well, these long-standing with the organization. You removed all the posterior membranes, but you didn't really attack any of those anterior, supposedly also against the ciliary body. So the only thing I think here that is I would have put in silicone oil and left it there, just if anything to try to preserve the volume of the eye indefinitely.
That's a very good point about hypotony, but I need to tell you the story about this. This was in a hospital where they didn't have ocular ultrasound machine, so it was done with an abdominal ultrasound probe for the documentation, and so then it didn't have the perfect ultrasound scan angles what we can manage, because that's a really big probe. So, but very good point, yes. So Danciron, I never used in my life. I've removed, oh, sorry, Rahila.
Malhar, I just had one comment. When you've done a 360-degree retinectomy, you've basically cut off the vascular supply to your peripheral retinal frill. If you leave it behind, thinking that it's going to reduce the risk of hypotony because you don't want exposed RPE, then you're basically going to get necrotic retina. You can get anterior PVR in that, and when that contracts circumferentially, you'll get disinsertion of your ciliary body. So you just run into problems later on. My feeling is that you should remove that peripheral retinal frill. And one of the things that I have started doing is I actually ablate the exposed RPE to reduce the RPE pump, to reduce the risk of hypotony.
That's too much of RPE, because as you can see, it's central 50-degree of retinal island. And
what's that RPE going to be doing anyway?
No, sure, but I'm just saying that, maybe additional significant time for surgery, that's not an issue, but whether that itself leads to corneal changes, overall view changes, and whether intentionally stimulating the RPE to proliferate, you can try to make it completely dead, but I don't know whether we can certainly achieve that.
But if I was training my fellows, I would advise them against leaving a potentially necrotic large frill of retina in the periphery beyond the retinectomy edge.
And I need to tell a short story on this as well, because the way I was trained, I mentioned that it was by the surgeons who were trained by Charles Keepens, and this was back home in India. That's the biggest retina institute in the world with 25 retinal surgeons. That's not important, but we used to see significantly worse situations with typical everyday similar closed funnel detachments, where we used to do not only lensectomy, vitrectomy, and retinectomy. At the time, I'm talking about 1999, year 2000, the surgeons used to do sphincterectomy for the iris as well, because those iris wouldn't dilate postoperatively. So yes, and nowadays when we talk that, how can you do that? But yes, not now, but at the time that was not the best option. So for me, start the retinal training with those severe most cases and seeing 360-degree retinectomy, 30-degree, 40-degree island for almost every day, and see the follow-up for a couple of years, not seeing the same problem what we see, Rahila, in UK. And I think perhaps it's the way they were trained and perhaps the way they are exposed to manage those cases routinely. 3-4 similar cases in a day, doing almost 7-8 cases every week, and then they develop their skills so fantastically. So I think that's where the key is. Ahmed, quick point, please.
Yes, I think operating on these cases is fine in young patients, but always warn them that you now have a non-seeing eye, but you may end up with a non-seeing and a painful eye, because if you fail to reattach the retina, they may get rubeosis and rubeotic glaucoma. And I think that's always something very important.
But if you have removed the peripheral thing, why do you expect?
No, if you fail to reattach the retina, they may end up with rubeosis.
Of course.
So, and that's because it's not like you're only losing the time of the operation, and you may win and you not lose. You may just end up with a painful eye, but I would still support operating, of course.
Sure. Close?
Well, that's the natural course anyway, that end. But I would like to add something to you, because I think it's a very beautiful comment. I always liken macrophages to sharks. You don't want to attract them, so don't leave any food for them. Anything they like to eat, remove it.
Okay, so moving to next. Murat, quickly.
I have a question about no light perception eyes. I think Dr. Farring, in his book, he had some operations on no light perception. I operated on a couple of no light perceptions. 1 month later, the patient developed 2200 vision.
Is it trauma cases you're talking about?
In traumatic cases, it was a car accident. What is Dr. Farring-Kunz about no light perception? Because he says that in his book that you can operate, and I did operate on no light perception.
Sure. Before that, if I can quickly ask the panel, that how many of you have operated on no perception of light, specifically in trauma? Trauma cases, yeah.
I think it depends on the time.
Sure.
Because if there's no light perception just after the accident or for a couple of days, you may operate him. If there's no light perception for months, don't operate the eye.
Sure. Please.
Yeah, exactly. The longest duration of no light perception after trauma, which resulted in some visual improvement in my hand, was 22 days. So if this eye, 4 months after the trauma is still no light perception, I would not do the surgery. But the general recommendation is the sooner the better. The more you wait, the less you can expect.
Sorry, what's the time zone? Did you say how many?
So again, I don't have a specific cutoff date.
Sure.
But in my hand, after 22 days, I have not had one that would have improved.
Right. Okay, so let's move to the next topic. I personally never have used Densiron in terms of using as a tamponade. I've removed a couple of which were operated somewhere else. And I would like to know Klaus's view. Do we really need this? This is quite old. This is early generation of Densiron, and I removed that in 2005 or 6. I think the first generation one.
Well, I occasionally show a video where I demonstrate how I try to remove Densiron from an eye, and I give up after 91 minutes because all this emulsification is just impossible to get out of the eye. I don't think that sort of substance has any long-term use in the eye. It's got no business being there.
Not for the removing, but do you really think that you would ever use this? Or have you used it ever?
No,
before?
because it's impossible to remove, and because it causes inflammation, and because it emulsifies, I would never ever use it.
And I think if you manage in a different way, maybe retinectomy, people say, oh, that leads to a lot of recurrence, etc., and that's why it's not good. And we discussed before that previously, and now perhaps in some of the continents, surgeons use silicone oil on top and heavy liquids in the bottom.
That works in Italian patients, but not in German patients.
That's crazy. Any comments, Didier, on Densiron?
I am not the man of the silicone oil, so please ask another guy. I can put silicone twice a year, no more than that.
Twice a year, and that would be 1,000 centistore. Yes. Okay, so perhaps one can do whatever they like, because even with the regulations in developed nations, you can get away with a lot of things, but I think not all the options are risk-free, and ultimately, unfortunately, the patients are the sufferers, so just be careful in choices. And a lot of time I realized that that's the training biases. We did the same survey in 2012 in UK, and I was significantly amazed to know that loads of surgeons use that, and some of the surgeons, they even use for failed macular holes. It doesn't explain to me how the physics work there. Just a quick point. Right, so the next question is, how many of the panel members prefer to peel ILM routinely to prevent ERM formation following retinal detachment repair? Routinely.
It depends.
No, routinely. All retinal detachments.
No, I know, but my answer depends. If
No, vitrectomy, yes.
the macula is detached, I will peel it. If it's not, I do not. Not because it would not prevent pucker formation. It does prevent pucker formation, but I just don't feel comfortable peeling an eye with full vision.
I'm not convinced, and I would love to get convinced by Klaus or Ferenc or anybody else, and I don't see the point in removing in all the detachments when we do vitrectomy, because my arguments are that what's the incidence, real incidence of epiretinal membrane formation after vitrectomy for reminerginous retinal detachment? And that's, well, arbitrarily I can say that certainly less than 20%. I'm being modest in that. So maybe 10%, but I'm just saying 20%. So by peeling the ILM, you're doing unnecessary 8 ILM peels out of 10 just to prevent 2 ERM. And then whether those patients really feel the distortion and whether they really need the ERM removal surgery. So I'm not convinced, and I would love to, as I said. So if you can convince me, Klaus.
First of all, I would differentiate between epiretinal membrane and pucker. I think they're two completely different conditions. A pucker is a type of PVR. It is PVR cells settling on the macula and then doing this. This is different from an ERM. And this pucker is what we're trying to prevent. Jersey has a very nice video in which he shows that an awful pucker case that has destroyed central vision. And the incidence of that after retinal detachment repair in the literature is anywhere between 10 and 20%. So that's a lot. Because if you prevent it, you're preventing a disaster. They're really causing disasters. And Sylvia and I have done this for many, many years. I presented it at the Vail meeting something like 9 years ago, and I thought I was going to be hung up on the next tree, but everybody thought that was a grand idea. We've been doing it ever since, and I think we've got well over 1,000 patients now. And we do remove the ILM in 20/20 eyes with attached macula. And there's only one occasion in the last years where I thought that I did something I shouldn't have done, and that was a very critical patient who reported microscotomata the next day, and that went away after a short while. So that's the only incidence where I thought that peeling the ILM in a 1.0 vision eye had caused damage, and we do it because it doesn't cause damage.
It doesn't do damage. Well, that's difficult to get convinced on, because I still remember Sebastian Wolf's publication a long time ago, and he showed under electron microscopic that it's not only peel zone of ILM, it's parapeel zone, which showed significant molar cell swelling, et cetera, and we don't talk quality of vision issue after VR surgery. And I have a theory, I may be completely wrong in a few years, but I think that in 5-7 years' time, we will be asking ourselves, the retina community across the globe, that why on earth we peel so much of the ILM?
But we've been doing it for 10 years.
Sure, but I think it's not completely traumatic, even if you do it.
It's not been biting us in our backsides.
It's an unnecessary surgery. So I love you, Dr. Luque, but it's an unnecessary surgery. So the patient comes into you for a vasectomy, and every time you do an appendectomy, I mean, it's an unnecessary surgery, and we can argue that you have to take out the appendix, but most people will live their lives without needing an appendectomy. So I personally don't do it. I know there's a lot of people out there in the world that do ILM dissection with everything that comes in that needs a vitrectomy, whether it's involving the macula or not, and I think that it's not necessary. And for every one case of complication, that's an unnecessary complication that would not have happened if you didn't take out the ILM. There are macular holes that can happen, and you take out the ILM when it doesn't need to be taken out. I mean, I don't do it, so I'm not convinced.
Sylvia, I'll come to you in a minute, just a minute. I mean, I don't observe that many ERMs after vitrectomy. I mean, I can look back for at least 13 years, and this is what I typically do for a long time, cryo under fluid exchange. Sometimes I mark it. I don't even mark for many times because I know where the breaks are. And what I'm saying is perhaps this can be a good idea, or maybe even staining the vitreomacular interface and seeing that negative pattern or different pattern. And once you see that, when you feel that that can have a bit higher risk of future problem, and then you peel ILM, perhaps. But anyway, Sylvia, quick point.
Yeah, I don't think that the comparison you made is right. So my experience goes back to 2000, which is 16 years now. And I've repeatedly gone through the numbers. First of all, I've looked to all macular on cases if there was one who lost vision. None lost vision, first. Second, we have youngsters in our team which slowly approach and go further their personal experience. They do not go for the routine ILM peel in attached maculas. They are the ones who experience postoperative cystoid macular edema and aberrant membrane formation. Third, when you look with a dye at the staining pattern, intraoperatively, you find that lots, at least 15%, have already aberrant membrane formation, and you can see this pattern. And those are candidates who highly probably postoperatively will have macular edema and advanced Perker formation. Third, or fourth now, if you go early to these cases, they do not experience visual loss. Those who get it secondarily, you go in when the vision is already down and you never got to the high range again. And so these are 4 arguments.
We'll see in a few years' time whether I will start doing it or not. Just to show some interesting slides from Global Trends in Retina at American Society of Retina Specialists Symposium. And what I'm trying to highlight here is the respondents of American Society of Retina Specialists from all the continents. What do they do in relation to ILM peel in ERM case? So you can see even for ERM, the opinion is significantly divided. And there are many, many surgeons who don't routinely peel ILM in ERM cases. I'm not saying that's the correct way, but whether that's a good idea in all eyes, I'm not sure, and that's why to push it for the retinal detachment for prophylactic purpose, for me personally, it's perhaps overkill. Right, so moving to another interesting topic for failed or large macular hole. And I have mentioned some of the comments in relation to inverted flap technique this morning, so I'm not going to repeat that, Jersey. So if I can start your video.
Okay, this is a case which was operated in another department 5 years before surgery, and it was... okay, you put his voice, yes?
Swept source OCT demonstrates that a large macular hole persisted. The surgery presented was performed 5 years later in 2013. ILM was peeled on the temporal side of the fovea, inverted, and placed on the surface of the macular hole. Because of the absence of lens capsule, sclerofixation IOL, and the lens diaphragm not being preserved, an air bubble appeared in the anterior chamber. Fluid air exchange was continued through this bubble. Inverted ILM flap was secured in place. Macular hole was closed and visual acuity improved.
You cut the beginning, and you must understand that this case was operated earlier in another department with vitrectomy, lentectomy, silicone oil injection, silicone oil removal for retinal detachment. And this was the last surgery 5 years after these earlier surgeries performed elsewhere.
Sure. So question to the panel. How many of you prefer to do inverted flap technique routinely for macular hole management? Except Jersey?
I started doing the inverted flap technique for more than 1 year.
Right, Jesse, I have already mentioned my points in the morning, but just to briefly summarize that, I still don't get this because we don't have good comparative data. And, that the last part of the video I was trying to pause was to show the scarring in the macular hole. Or perhaps you can clarify, because in different continents I've spoken to different surgeons, and a lot of surgeons prefer to put everything in the macular hole. And if that's not the way you recommend, maybe you want to clarify that approach. And I think, if I am correct, you have stopped doing that original technique which you described long time ago. You have this modified technique which you just show the video, right?
Yes.
Okay.
But I never presented to put ILM into the hole. That is an important issue discussed on several meetings.
Absolutely.
I always put ILM on the surface of the retina, on the top of the retina, not inside the hole. But some people, I do not understand why, falsely understand our first videos presented in 2009 and think that we introduce the ILM into the hole, not into the hole, on the top.
Like this OCT, I can say that this is the least amount of scarring I've ever seen on inverted flap technique in one of the presentations. So I have seen all kind of, central thing, and we need photoreceptors for improvement of vision and not scarring.
Yes.
So I'm not trying to be so critical, I'm just trying to convince myself why it works, and I was impressed when you showed me a couple of years ago one flap, semicircular flap going on a large macular hole and just air injection you showed me during ASRS, I think 3 years ago. And I was impressed because at the time, next day, you showed OCT and it was closed. So perhaps that's a good idea, but I think putting everything on top, I'm not sure. Klaus, you are quite eager to make any comment?
No.
No? Okay. Any other comments?
I will explain to you why. Because ILM is a base membrane. And the base membrane works as a scaffold for cells for proliferation. And in this specific case, we at least feel or hope that this base membrane allows retina cells to migrate, move, reapproximate or regenerate on the base of this base membrane and improve the anatomic situation in the macula. And we observed that with spectral domain and swept source OCT for years.
I understand that, but when I get frustrated when the surgeons, not of course you, but in different meetings, when they show that they primarily prefer inverted flap technique, regardless of the size of the macular hole, and they promote this concept, which gets into the heads of the new generation of surgeons or fellows, and then they just promote it furthermore. So in a generation time, the overall concept gets significantly muddled. So I'm just trying to highlight that we don't have comparative data even for the failed one. So whether I would prefer to give an opportunity for that eye to have a longer acting gas bubble. I don't routinely do face down positioning for macular holes. I always do phaco-vitrectomy for presbyopic age group. So we will come to a point in a minute. I'm just going to next slide. So that's silicone oil, and of course silicone oil is absolute no-no, and I have seen a couple of publications where surgeons have used heavy silicone oil for failed macular holes, and I don't get that. Right, Didier, how do you manage a patient with lamellar macular hole? Now, this is one of my patients a long time ago, and this is just to show a follow-up over a year, and we know that that remains stable for a long time. But for example, if the patient was 2020 and now it's 2025, with epiretinal membrane, you just need to assume on this OCT that there's ERM and CMO and approximate size is 350 micron.